Join us as we explore how a dual mechanistic approach is thought to work in advanced renal cell cancer. The tumor microenvironment is a heterogeneous population of cells that respond to biological stimuli, contributing to tumor growth. Dysregulated signaling of these cells can lead to abnormal cell growth and survival. Preclinical studies have shown that dysregulated signaling of receptor tyrosine kinases, or RTKs, such as AXL, a member of the TAM family, MET, and VEGFR, play a role in tumor angiogenesis and tumor cell proliferation and metastasis. Signaling of some RTKs, such as MET, AXL, and VEGFR, can also modulate the anti-tumor immune response, which involves the activity of several immune cells, including dendritic cells, effector T cells, and immunosuppressive cells, such as regulatory T cells, or Tregs, myeloid-derived suppressor cells, or MDSCs, and M2 tumor-associated macrophages. The anti-tumor immune response may begin with dendritic cells capturing tumor-associated antigens and presenting them to T cells, which leads to T cell activation and proliferation. Activated T cells can infiltrate the tumor and promote T cell-mediated killing of cancer cells. Inhibitory immune checkpoint proteins, such as PD-1 and PD-L1, help keep the immune system in check by preventing T cell activation. However, cancer cells can exploit this mechanism by upregulating immune checkpoints to evade immune detection. In ARCC, preclinical studies have shown that dysregulated signaling of MET, AXL, and VEGFR can dampen the anti-tumor immune response in several ways, including increasing immunosuppressive cell types, impairing antigen presentation, reducing cytotoxic T cells and T cell activation, and reducing tumor recognition through increased PD-1, PD-L1 expression. The dysregulated signaling of immune checkpoints, together with MET, AXL, and VEGFR, among other RTKs, may help hinder the anti-tumor immune response and contribute to tumor growth. CABOMETYX, cabozantinib, in combination with nivolumab, is indicated for the first-line treatment of patients with advanced RCC. CABOMETYX is the only approved multi-targeted tyrosine kinase inhibitor that inhibits MET, AXL, and VEGFR, among other RTKs. Based on preclinical models, cabozantinib has also been shown to inhibit RET, ROS1, Tyro3, MER, KIT, TRKB, FLT3, and TIE2. These RTKs are known to be involved in both normal cellular function and pathologic processes. Inhibiting these RTKs with CABOMETYX may lead to adverse events. Please see the important safety information later in this video for more details. In preclinical models, inhibiting MET, AXL, and VEGFR has been shown to block angiogenesis and cell proliferation and may alter the tumor microenvironment by reducing levels of select immunosuppressive cells, and by promoting tumor recognition by reducing negative immune checkpoints, increasing antigen presentation, and increasing cytotoxic T cells and normalizing the vasculature to promote immune cell infiltration. Inhibiting immune checkpoint proteins such as PD-1 and PD-L1 using agents known as immuno-oncology therapies, or IOs, can also alter the tumor immune microenvironment. In this case, OPDIVO, nivolumab, inhibits PD-1 to help activate T cells and mediate attack of tumor cells, thereby helping to restore immune function. CABOMETYX and OPDIVO offer a dual mechanistic approach in ARCC and may help inhibit some of the signaling pathways driving tumor growth. Learn more about this dual mechanistic approach for ARCC.
Indications. CABOMETYX, cabozantinib, is indicated for the treatment of patients with advanced renal cell carcinoma, RCC. CABOMETYX, in combination with nivolumab, is indicated for the first-line treatment of patients with advanced RCC. Important safety information, warnings and precautions. Hemorrhage. CABOMETYX can cause severe and fatal hemorrhages. The incidence of grade 3 to 5 hemorrhagic events was 5% in CABOMETYX patients in RCC, HCC, and DTC studies. Discontinue CABOMETYX for grade 3 to 4 hemorrhage and before surgery. Do not administer to patients who have a recent history of hemorrhage, including hemoptysis, hematemesis, or melena. Perforations and fistulas. Fistulas, including fatal cases, and gastrointestinal GI perforations, including fatal cases, each occurred in 1% of CABOMETYX patients. Monitor for signs and symptoms, and discontinue CABOMETYX in patients with grade 4 fistulas or GI perforation. Thromboembolic events. CABOMETYX can cause arterial or venous thromboembolic events. Venous thromboembolism occurred in 7%, including 4% pulmonary embolism, and arterial thromboembolism in 2% of CABOMETYX patients. Fatal thrombotic events have occurred. Discontinue CABOMETYX in patients who develop an acute myocardial infarction or serious arterial or venous thromboembolic events. Hypertension and hypertensive crisis. CABOMETYX can cause hypertension, including hypertensive crisis. Hypertension was reported in 37%, 16% grade 3, and less than 1% grade 4 of CABOMETYX patients. In CABINET, N equals 195, hypertension occurred in 65%, 26% grade 3, of CABOMETYX patients. Do not initiate CABOMETYX in patients with uncontrolled hypertension. Monitor blood pressure regularly during CABOMETYX treatment. Withhold CABOMETYX for hypertension that is not adequately controlled. When controlled, resume at a reduced dose. Permanently discontinue CABOMETYX for severe hypertension that cannot be controlled with antihypertensive therapy or for hypertensive crisis. Cardiac failure. CABOMETYX can cause severe and fatal cardiac failure. Cardiac failure occurred in 0.5% of patients treated with CABOMETYX as a single agent, including fatal cardiac failure in 0.1% of patients. Consider baseline and periodic evaluations of left ventricular ejection fraction. Monitor for signs and symptoms of cardiovascular events. Withhold and resume at a reduced dose upon recovery, or permanently discontinue depending on the severity. Diarrhea. CABOMETYX can cause diarrhea, and it occurred in 62%, 10% grade 3, of treated patients. Monitor and manage patients using antidiarrheals as indicated. Withhold CABOMETYX until improvement to less than or equal to grade 1. Resume at a reduced dose. Palmar-plantar erythrodysesthesia, PPE. CABOMETYX can cause PPE, and it occurred in 45% of treated patients, 13% grade 3. Withhold CABOMETYX until PPE resolves or decreases to grade 1, and resume at a reduced dose for intolerable grade 2 PPE or grade 3 PPE. Hepatotoxicity. CABOMETYX in combination with nivolumab in RCC can cause hepatic toxicity with higher frequencies of grades 3 and 4 ALT and AST elevations compared to CABOMETYX alone. With the combination of CABOMETYX and nivolumab, grade 3 and 4 increased ALT or AST were seen in 11% of patients. Monitor liver enzymes before initiation of treatment and periodically. Consider more frequent monitoring as compared to when the drugs are administered as single agents. Consider withholding CABOMETYX and/or nivolumab, initiating corticosteroid therapy, and/or permanently discontinuing the combination for severe or life-threatening hepatotoxicity. Adrenal insufficiency. CABOMETYX, in combination with nivolumab, can cause primary or secondary adrenal insufficiency. Adrenal insufficiency occurred in 4.7%, 15 out of 320, of patients with RCC who received CABOMETYX with nivolumab, including grade 3, 2.2%, and grade 2, 1.9% adverse reactions. Withhold CABOMETYX and/or nivolumab, and resume CABOMETYX at a reduced dose depending on severity. Proteinuria. Proteinuria was observed in 8% of CABOMETYX patients. Monitor urine protein regularly during CABOMETYX treatment. For grade 2 or 3 proteinuria, withhold CABOMETYX until improvement to less than or equal to grade 1 proteinuria. Resume CABOMETYX at a reduced dose. Discontinue CABOMETYX in patients who develop nephrotic syndrome. Osteonecrosis of the jaw, ONJ. CABOMETYX can cause ONJ, and it occurred in less than 1% of treated patients. Perform an oral examination prior to CABOMETYX initiation and periodically during treatment. Advise patients regarding good oral hygiene practices. Withhold CABOMETYX for at least 3 weeks prior to scheduled dental surgery or invasive dental procedures. Withhold CABOMETYX for development of ONJ until complete resolution. Resume at a reduced dose. Impaired wound healing. CABOMETYX can cause impaired wound healing. Withhold CABOMETYX for at least 3 weeks prior to elective surgery. Do not administer for at least 2 weeks after major surgery and until adequate wound healing. The safety of resumption of CABOMETYX after resolution of wound healing complications has not been established. Reversible posterior leukoencephalopathy syndrome, RPLS. CABOMETYX can cause RPLS. Perform evaluation for RPLS and diagnose by characteristic finding on MRI any patient presenting with seizures, headache, visual disturbances, confusion, or altered mental function. Discontinue CABOMETYX in patients who develop RPLS. Thyroid dysfunction. CABOMETYX can cause thyroid dysfunction, primarily hypothyroidism, and it occurred in 19% of treated patients, 0.4% grade 3. Assess for signs of thyroid dysfunction prior to the initiation of CABOMETYX and monitor for signs and symptoms during treatment. Hypocalcemia. CABOMETYX can cause hypocalcemia, with the highest incidence in DTC patients. Based on the safety population, hypocalcemia occurred in 13% of CABOMETYX patients, 2% grade 3 and 1% grade 4. Monitor blood calcium levels and replace calcium as necessary during treatment. Withhold and resume CABOMETYX at a reduced dose upon recovery, or permanently discontinue CABOMETYX depending on severity. Embryo-fetal toxicity. CABOMETYX can cause fetal harm. Advise pregnant women of the potential risk to a fetus, and advise females of reproductive potential to use effective contraception during treatment with CABOMETYX and for 4 months after the last dose. Adverse reactions. The most common, greater than or equal to 20% adverse reactions are CABOMETYX as a single agent, diarrhea, fatigue, PPE, decreased appetite, hypertension, nausea, vomiting, weight decreased, and constipation. CABOMETYX in combination with nivolumab, diarrhea, fatigue, hepatotoxicity, PPE, stomatitis, rash, hypertension, hypothyroidism, musculoskeletal pain, decreased appetite, nausea, dysgeusia, abdominal pain, cough, and upper respiratory tract infection. Drug interactions. Strong CYP3A4 inhibitors. If co-administration with strong CYP3A4 inhibitors cannot be avoided, reduce the CABOMETYX dosage. Avoid grapefruit or grapefruit juice. Strong or moderate CYP3A4 inducers. If co-administration with strong or moderate CYP3A4 inducers cannot be avoided, increase the CABOMETYX dosage. Avoid St. John's wort. Use in specific populations. Lactation. Advise women not to breastfeed during CABOMETYX treatment and for 4 months after the final dose. Hepatic impairment. In patients with moderate hepatic impairment, reduce the CABOMETYX dosage. Avoid CABOMETYX in patients with severe hepatic impairment. Please see accompanying full prescribing information. You are encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088.
For more information on this dual mechanistic approach and to learn if CABOMETYX may be appropriate for your patients with ARCC on first-line therapy, please visit www.cabometicsHCP.com.